Hello there. So we were studying gastroenterology and let's continue further. So here we have a question. Uh, a 28-year-old female presents with a 4-month history of diarrhea, lethargy, weight loss. She complains of abdominal discomfort, passing stools more than 6 times a day. An endoscopy was performed which shows cobblestone mucosa. So they are asking about the likely diagnosis in this case. So as we can see here, um, cobblestone mucosa is the giveaway. So it is a case of Crohn's disease, and because it is pathognomic of Crohn's disease, and therefore this cobblestone mucosa is like a classical feature of Crohn's disease. So let's study about Crohn's disease, and alongside we'll also study about ulcerative colitis. A few important points, or let's say the differences. Crohn's disease versus ulcerative colitis. First, Crohn's disease. It can affect any part of the GI tract from mouth to anus. Can affect any part of the GI tract from mouth to anus. Second, usually non-bloody diarrhea. Usually non-bloody diarrhea. Third, abdominal mass palpable in right iliac fossa. Abdominal mass palpable in right iliac fossa. Increased goblet cells on histology. Fourth is increased goblet cells on histology. Increased goblet cells on histology. Fifth, granulomas seen on histology. Now, fifth, granulomas seen on histology. Sixth, weight loss is more prominent. Weight loss is more prominent. Seventh, transmural skip lesions, cobblestone appearance on endoscopy. Seventh is transmural skip lesions and cobblestone appearance on endoscopy. Transmural and skip lesions and cobblestone appearance on endoscopy. Now, ulcerative colitis. Ulcerative colitis affects the mucous membrane starting from rectum. So ulcerative colitis, it affects the mucous membrane. It affects the mucous membrane starting from rectum. Second, bloody diarrhea more common compared to Crohn's disease. Bloody diarrhea more common compared to Crohn's disease. Third, abdominal pain in left lower quadrant. Abdominal pain in left abdominal pain in left lower quadrant. Now another is decreased goblet cells on histology. Decreased goblet cells on histology. Then granulomas are infrequent on histology. Then primary sclerosing cholangitis is more common. Primary sclerosing cholangitis is more common. Then last one is loss of hostrations, drain pipe colon seen on barium enema. Loss of hostration and drain pipe colon seen on barium enema. So these are the features of Crohn's disease and ulcerative colitis. Let's once go through them quickly. Crohn's disease, it can affect any part of the GI tract from mouth to anus, whereas ulcerative colitis only affects the mucous membrane starting from rectum. Crohn's disease, usually it is having non-bloody diarrhea. Ulcerative colitis, it is more commonly having bloody diarrhea. In Crohn's in Crohn's disease, abdominal mass is palpable in right iliac fossa. In Crohn's disease, abdominal mass is palpable in right iliac fossa. In ulcerative colitis, abdominal mass is palpable in abdominal pain is present in left lower quadrant. In ulcerative colitis, there is abdominal pain in left lower quadrant. In Crohn's disease, there is abdominal mass in right iliac fossa, which is palpable. Ulcerative colitis, there is uh, abdominal pain in left lower quadrant. In Crohn's disease, goblet cells increase on histology and granulomas are also seen on histology. Whereas in ulcerative colitis, goblet cells decrease on histology and granulomas are also less frequent on histology. So in Crohn's disease, in ulcerative colitis, goblet cells will be less, granulomas will also be less on histology. Both will be less. Whereas in Crohn's disease, both goblet cells as well as granulomas will be more, or they are seen or present on histology. In Crohn's disease, weight loss is more prominent, and in Crohn's disease, there are transmural skip lesions and cobblestone appearance seen on endoscopy. So Crohn's disease is transmural, and there are skip lesions, and there is cobblestone appearance on endoscopy. Whereas in ulcerative colitis, it's only involving the mucous membrane starting from rectum. We know in this there is loss of hostrations. There is loss of hostrations, primary sclerosing cholangitis, and drain pipe colon seen on barium enema. In Crohn's disease is transmural, skip lesions are present, and cobblestone appearance is seen on endoscopy. In ulcerative colitis, there is loss of hostrations, there is primary sclerosing cholangitis, and there is drain pipe colon seen on barium enema. And other features we know, Crohn's disease, any part of the GI tract from mouth to anus, and usually there is non-bloody type of diarrhea. Abdominal mass is palpable in right iliac fossa. Increased goblet cells, increased granulomas, increased goblet cells, and more granulomas seen on histology. Weight loss is more prominent. Transmural, skip lesions, and uh, cobblestone appearance seen on histology. Whereas in ulcerative colitis, it affects only the mucous membrane starting from rectum. It affects only the mucous membrane starting from rectum, and there is bloody diarrhea, more common as compared to Crohn's disease. There is abdominal pain in the left lower quadrant, and there is decreased goblet cells as well as decreased granulomas seen on histology. Uh, in this ulcerative colitis, there is loss of hostrations and primary sclerosing cholangitis, and lead pipe colon is lead drain pipe colon. Drain pipe colon is seen in barium enema. So these are certain features. So another thing which we have to study is the management of Crohn's disease. Management of Crohn's disease. The Crohn's disease management is divided into inducing remission and maintaining remission. Inducing remission and maintaining remission. Inducing remission. For inducing remission, we have to give corticosteroids, and if corticosteroids are contraindicated, then we have to use budesonide or aminosalicylates such as mesalazine if mild to moderate disease is present. So for inducing remission, we give corticosteroids if in case corticosteroids are contraindicated, then use budesonide or aminosalicylate such as mesalazine if mild to moderate disease. Now there are many more medications which can be used as add-on therapies, but here we like to keep things simple, and mnemonic would be C for Crohn's, C for corticosteroids as the first line to reduce remission. So C for Crohn's, C for corticosteroids as first line to induce remission. Maintaining remission. Now medications used for remission include azathioprine, mercaptopurine, and methotrexate. So medications used for remission include azathioprine, mercaptopurine, and methotrexate. So methotrexate, azathioprine, and mercaptopurine for maintenance of remission. So management of Crohn's disease, Crohn's, C for Crohn's, C for corticosteroids. Management of Crohn's disease divided into two parts. First is inducing remission. Second is maintenance of remission. Inducing remission, it is done by corticosteroids. If corticosteroids are contraindicated, then we use budesonide or aminosalicylates such as mesalazine. Budesonide or aminosalicylates such as mesalazine if mild to moderate disease is present. For maintenance of remission, we use MAM, that is methotrexate, methotrexate, azathioprine, and mercaptopurine. For maintenance of remission, we use MAM, that is methotrexate, azathioprine, and mercaptopurine. For inducing corticosteroids, if corticosteroids contraindicated, then budesonide or aminosalicylates such as mesalazine. Here, methotrexate, azathioprine, and mercaptopurine. Okay, this is the management part. So diagnosis of Crohn's disease is quite clear here because there is lethargy, weight loss, which are non-specific signs which can occur in Crohn's disease. We studied in Crohn's disease there is significant weight loss. The giveaway here is the cobblestone mucosa, which is seen on endoscopy, which is pathognomonic for Crohn's disease. Okay, cobblestone appearance. We already learned that for Crohn's disease, few important things are like um, transmural, skip lesions, and cobblestone appearance in endoscopy. For ulcerative colitis, apart from all the other things, there are loss of hostrations, primary sclerosing cholangitis, and there is drain pipe colon seen in barium. So these are certain things. Let's move further. Corticosteroids, budesonide, or aminosalicylates such as mesalazine. Okay, let's move ahead. Now we have a 33-year-old woman who has severe upper abdominal pain with radiation to the back within 24 hours of removing gallstones by endoscopic retrograde cholangiopancreatography, that is ERCP. The pain is eased when she leans forward. She reports some nausea and vomiting but denies any diarrhea. Jaundice is there. Epigastric region is tender on palpation. Her blood pressure is 120/80. Temperature is 37.3. What is a single most likely reason for her signs and symptoms? So here we have to study about first abdominal pain differentials and second acute pancreatitis. The likely cause here is acute pancreatitis, pancreatitis being one of the most frequent post ERCP complications. Pancreatitis is one of the most frequent post endoscopic retrograde cholangiopancreatography complications. So post ERCP, one of the most frequent complications is pancreatitis. Incidence is 20%. Ascending cholangitis may also have similar presentation, but here she is not having any fever. The likely cause is therefore acute pancreatitis. But in acute pancreatitis also we can have mild fever. So first, let's study about acute pancreatitis. Etiology: vast majority of the cases in the UK are caused by gallstones and alcohol. They are caused by gallstones and alcohol. A popular mnemonic to remember is get smashed. So, mnemonic for etiology of acute pancreatitis is get smashed. So, acute mnemonic get smashed. So they will include gallstones, ethanol, trauma, steroids, mumps, others include Coxsackie B virus, then autoimmune conditions, autoimmune conditions such as polyarthritis nodosa, and autoimmune disease such as polyarthritis nodosa and ascaris infection, scorpion venom, then hypertriglyceridemia, hypertriglyceridemia, hyperchylomicronemia, then hypercalcemia, and hypothermia. Another is ERCP. And last one is certain drugs. ERCP is retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography. And the drugs would include azathioprine, mesalazine, didanosine, bendroflumethiazide, bendroflu bendroflumethiazide, bendroflumethiazide, furosemide, pentamidine, steroids, and sodium valproate. These are the causes. Get smashed. Gallstones, ethanol, trauma, steroids, mumps, other viruses such as Coxsackie virus, then autoimmune conditions such as polyarthritis nodosa and ascaris infection, then scorpion bite, scorpion venom, and hypertriglyceridemia, hyperchylomicronemia, hypercalcemia, and hypothermia. Then ERCP, that is endoscopic retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography, then certain drugs such as azathioprine, mesalazine, didanosine, bendroflumethiazide, furosemide, pentamidine steroids, and sodium valproate. Now, clinical features. Clinical features include sudden severe epigastric or central abdominal pain. Sudden severe epigastric or central abdominal pain which is radiating to back or sitting forward may relieve it. And vomiting is prominent. So there is sudden severe epigastric or central abdominal pain which radiates to back and sitting forward may relieve it. Second, vomiting is prominent. Other features to look out for are tachycardia, fever, jaundice, shock, right abdomen with rigid abdomen with local or general tenderness, rigid abdomen with local or general tenderness, then peri-umbilical bruising. Cullen sign. Cullen sign. Other features, uh, the clinical features are sudden severe epigastric or central abdominal pain. Clinical features include sudden severe epigastric or central abdominal pain which is radiating to back and sitting forward can relieve it. Second, vomiting is prominent. Other features are such as tachycardia, fever, jaundice, shock, rigid abdomen with local generalized tenderness, and peri-umbilical bruising. This is called as Cullen sign. Peri-umbilical bruising called as Cullen sign. Now let's go to the investigations. Investigations will include raised serum amylase, however, serum lipase levels are more sensitive and more specific. Now, CT scan Second is CT scan with contrast enhancement may be diagnostic, where clinical and biochemical results are equivocal. So CT scan with contrast enhancement may also be diagnostic. Now, last, management. Management first, resuscitate with IV fluids, IV analgesia. Third, nutritional support, that is parenteral feeding. IV antibiotics in severe cases. IV antibiotics in severe cases. So investigations will include raised serum amylase level. However, serum lipase levels are more sensitive and more specific. Raised serum amylase level is also diagnostic. And apart from that, CT scan with contrast enhancement may also be diagnostic. Serum amylase level would be more than 1000 unit per ml or 3 times of normal limit. 3 times of normal limit. Management would be done by resuscitation with IV fluids, IV analgesia, then nutritional support by parenteral feeding, and IV antibiotics. IV antibiotics in severe cases. This is about acute pancreatitis. Now we'll compare acute pancreatitis with acute cholangitis. Now in acute pancreatitis, pain is radiating straight through to the back, which is better on sitting up or leaning forward. Second, general abdominal tenderness with reduced bowel sounds. Generalized abdominal tenderness with reduced bowel sounds. This is suggested by, now confirmed by. Confirmed by elevated serum lipase and amylase and CT scan pancreas. Now acute cholangitis suggested by fever, right upper quadrant abdominal pain, and jaundice. Second, hypotension. And third, leukocytosis. Now confirmed by ultrasound scan. So acute cholangitis is suggested by fever, right upper quadrant abdominal pain, jaundice, hypotension and leukocytosis. It is confirmed by ultrasound scan of gallbladder and biliary ducts and blood culture. So this is a comparison between acute pancreatitis and acute cholangitis. In acute pancreatitis, it is suggested by pain radiating straight to the back, which gets better on sitting up and leaning forward, and there is generalized abdominal tenderness with reduced bowel sounds. And it is confirmed by elevated serum lipase and amylase levels and CT scan of pancreas. Acute cholangitis, it is suggested by fever, right upper quadrant abdominal pain, and jaundice, and there is hypotension and leukocytosis. And it is confirmed by ultrasound scan of gallbladder, biliary ducts and blood culture.